neuro today, a little phys, little neuroanatomy, neurophys, and a little pathology. First thing I want to discuss is the basal ganglia. Okay, just these are my notes, but I want to discuss the basal ganglia. I want you to remember that the basal ganglia is responsible for movement, right? Movimiento. In general, whenever you think basal ganglia, just think movement.
Okay.
Do you by any chance remember the blood supply to the basal ganglia? That's right. It's called lenticular.
Oh yeah.
Right?
It's
Striatal.
yeah.
So arteries. Muy bien. So arteries, right? Lenticular striatal arteries. That's the blood supply to the basal ganglia. Okay. So don't forget that, because if I have, let's say, hypertension and then maybe a hemorrhage of those arteries, well, guess what? We're going to have movement disorders, right? Or if, let's say, what's this called? Bilirubin deposits or copper deposits in the basal ganglia, then we're going to have movement disorders, okay? Like in Wilson's disease or kernicterus. All right?
All right.
All right, good. So that was just the background. Here, I want you to follow it in this. We're going to follow it starting over here where it says movement. Okay.
Okay.
We're going to start here. So I want you to know that the thalamus helps with stimulation of movement. All right. The thalamus helps with the stimulation of movement. Here we have the globus pallidus. The globus pallidus inhibits the thalamus. O sea, globus pallidus does not want movement. So he inhibits the globus pallidus. And you already know, doctora, every hater has a friend, right? Because misery loves company. Every hater has a friend. So the subthalamic nucleus is globus pallidus' friend. And he's like, yeah, you tell that thalamus to be quiet. You inhibit that thalamus, man. You got this. Luckily, though, the thalamus has two friends, right? Caudate and putamen. And they inhibit the globus pallidus because they want movement. All right. And if for whatever reason the caudate and putamen, if they can't suppress the globus pallidus, they're going to get their big bad brother, the substantia nigra, and then he's going to come in and he's going to stimulate them to further inhibit globus pallidus. Okay. So if I have a problem with the substantia nigra, well, then that's called Parkinson's disease. In Parkinson's disease, don't they have like a resting tremor, bradykinesia, cogwheel rigidity, shuffling gait? It's all movement disorders.
That's
why. That's why. Oh, connections. It's good. In Huntington's, they're always dancing, right? They have a funny little dance, right? That's the caudate. They have caudate atrophy, caudate nucleus atrophy. You see? So movement disorders. The subthalamic nucleus, if lesioned, can lead to hemibolismus. Hemibolismus is half of Huntington's. Hemibolismus is half of Huntington's. So in Huntington's, they're dancing, both arms and legs, right, are shaking. They're shaking their booty. Everything is moving. And with hemibolismus, half is just one arm or one leg that's dancing. Everything else is fine, tranquilo, calm. Okay? That's the basal ganglia. Again, lenticular striatal arteries and just movement. All right, kernicterus is something that can affect this, kernicterus, as well as Wilson's disease. Okay? That was the first image. Here's image number 2. All right, doc, here we have our brain. We're going to focus on this guy first. All right, here's our brain. I want you to know that the lateral side of the brain usually heads towards the face and the arms. The lateral side of the brain usually goes to the face and the arms. And the blood supply is the middle cerebral artery. Okay? Anterior /midline, that goes to the legs and the lower trunk, irrigated by the anterior cerebral artery. And posterior cerebral artery is in the back, usually is associated with vision. Okay? So there's a concept hidden in this, and the concept is this. For the most part, in neuro, anything that's midline goes to the legs or the lower trunk. Anything that is lateral goes to the face or the arms. You got it?
Yeah.
Okay, good. Here I have a cerebellum. I have the vermis and the cerebellar tonsils. We have two cerebellar tonsils and one vermis. The vermis is in the middle. So the vermis has fibers going to what area of the body?
The vermis.
Mm-hmm. Right here. What area of the body does he go to or does he sense?
It has to do with the balance and everything.
Right. So therefore, legs and lower trunk.
Mhm.
You see that? Why? Because he's midline. I'll say it again. Anytime it's midline, it goes to the legs and the lower trunk. Anytime something is lateral in neuro, it goes to the
Face and
arms.
all.
Yeah, face and arms. Here I have the dorsal column, right? The dorsal column, dorsal root ganglia, right? We have gracilis and cuneatus.
Mhm.
Where does gracilis receive its sensory from?
Sensory from
Where is he found? Just look right here.
in the posterior horn of the
Yeah, posterior, but is he lateral or medial?
no medial, medial.
Medial. So where does he go? Or where does he sense? From where does he?
To the legs and to the trunk.
Yeah, the legs and lower trunk. Exactly. So therefore, adivina, right? Guess. Cuneatus.
It's go to the arms.
Look at that. The
So
arms. Wow. You see? It repeats itself. Here's another image of a brain. What I drew here were ventricles. Now, what I'm trying to depict here is, let's say we have ventricles that are oversized, right? Oversized. If the ventricles are large, they can actually cause damage to the midline fibers, right?
mhm.
What's if they damage the midline fibers, doc? What part of the body will be affected?
The contralateral.
If they damage the midline fibers, what part of the body will be affected?
Oh, okay, okay, okay. Got it, got it. The midline is going to go to the legs and to the trunk.
Exactly. You see, I'm not asking hard questions. It's the same concept
No,
over
no,
and over
no.
again. Yeah. Good. So yes, legs and lower trunk, right? With that being said, these patients with this disease is called normal pressure hydrocephalus. The brain shrinks. You have brain atrophy, but the ventricles remain the same size. So just because of the size difference, it causes compression of the midline fibers, and then that's why they say they're wet, wobbly, and wacky. They're wacky because of the dementia, because of the cerebral atrophy. They're wobbly because of the compression of the midline fibers, and they're wet because of compression of the midline fibers, right? They urinate themselves.
Hmm.
You see?
Yeah.
Good. All right. So that was this concept. Okay. Just want to discuss this one also. Don't forget it. All right. Let's see here. Next one. Let's get to nice. The spinal cord and some tracks. I'm going to focus on three main must-know tracks: spinal thalamic, dorsal root column or dorsal column, and cortical spinal tract. Spinal thalamic, dorsal column, and cortical spinal tract. Those are the three main ones I need you to focus on. Okay.
Okay.
So we're going to start off with cortical spinal tract. For the most part, he deals with movement. That's his thing. He deals with movement. That's what he does. Okay. What that means is if I damage my cortical spinal tract, I'm going to have movement issues, right? Like maybe
Mhm.
hyperreflexia, maybe hyporeflexia, right? Maybe what's this called? Hyperextension. You see,
Okay.
excessive extension, like maybe in like I don't know, Brzezinski sign rings a bell.
Yeah.
Yeah. Okay, good. That's upper versus lower motor neuron Lesions, right? Fasciculations is another finding.
Yeah.
Okay, good. Spinal thalamic, on the other hand, he deals with pain and temperature. Pain and temperature. So if I lesion spinal thalamic tract, pain and temperature is gone. Dorsal column, vibration, position, and proprioception. The V's and the P's. The V's and the P's. All right. If they give me a combination of V's and P, I already know it's the dorsal column. Okay. Here's a hint. It seems like they are they really love to mention vibration above all else. I just something I've noticed from the questions I've seen. They really like to ask about vibration. Doesn't mean it's it's the only thing they're going to ask. Okay, they will mention position and proprioception, but definitely be on the lookout for vibration. Okay, V's and P's. All right. Yeah. Okay, so here I have my spinal cord, anterior, posterior, right? We have the anterior horns, the posterior horns, nucleus pulposus, right? Right in the middle.
Yeah.
So what I want you to realize is notice how I put M and S. Right? What are these M's and S? What does this mean? Right. So for the most part, the anterior portion, okay, of the spine is motor for the most part, meaning like 90%, I'll say. Mostly motor and some sense. See that? Mostly motor and a little bit of sense. Not a lot, a little bit. Mostly motor though. However, the posterior side, you already guessed it, mostly sense. A little bit motor. Okay, something I've noticed. Okay, good. So what do I mean? Well, of these three tracks, which one is motor?
The corticospinal tract.
Exactly. All the others are sense.
Mm-hmm.
So where do you think the corticospinal tract is going to be predominantly?
Anterior.
Here and here. And then we have a little bit of him over here and over here. They call lateral corticospinal tract. Right? The lateral corticospinal tract versus anterior. You say, what's the difference? Lateral goes to the legs. In this case, lateral corticospinal tract specifically goes to the legs.
Okay, that's the exception of the previous that we discussed.
Exactly, that's the exception. But again, if you're ever unsure, just fall back to the 90%. Okay.
Okay.
But this is the only exception. Maybe they ask it, maybe they don't. Either way, though, like I said, because it's lateral and posterior, like, well, you have to be the exception because for the most part, motor is anterior, not posterior. See?
Yeah, exactly.
All right, exactly. Good, so that's corticospinal tract, okay? Then I have my spinal thalamic tract, which you see is doing this. Now, what I'm drawing is, what he does is he crosses at the anterior white commissure. This area right here is known as my anterior white commissura, right? Commissure, all right? Anterior white commissure. So basically this area, if damaged for whatever reason, would affect pain and temperature, right? So maybe a patient has a syringomyelia, right? An enlarging syrinx, right? Big old balloon, if you will. Or what about the blood supply, right? We have two arteries right here. What if the blood supply to the anterior spine was damaged? Do you know the arteries to the anterior spinal cord? You know what they're called? Can you guess? Can you guess?
Guess.
The arteries to the anterior spinal cord. Are you ready? It's a huge name. They're called the boom, 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 anterior spinal arteries. Boom, boom.
Oh, ASA. Yes.
Oh man, get another sheet of note paper. It's a lot to write. So anterior spinal arteries. Okay, so if I were to have a lesion or some sort of infarct to the anterior spinal arteries, well, then the anterior portion of my spine will be gone, right? We'll have an issue, and then I'll have movement disorders and pain and temperature disorder. You see?
Yeah. Versus
somebody who has, let's say, like a B12 deficiency. That can cause dorsal column issues. Or maybe somebody's being a little nasty, and they got a little tabes dorsalis from syphilis. Or they're extra nasty, extra weird, and they did some weird things to a fish called delatum. Who knows what they've done with this freshwater fish? But whatever the case may be, it causes dorsal column disease. Right? These are just 3 examples. But you know how they all present? Decreased vibration, decreased position, decreased proprioception, all of them.
Mm-hmm.
You see that?
Yeah,
Good.
the B's and the B's.
You see that? The V's and the P's. Good. All right. That's this image. Next one. I told you it's a lot. All right. I know this looks like a light bulb. This is not a light bulb. This is your brain. Here's your brain, spinal cord. All right. So let's discuss. Oops. Let's discuss what I have drawn here. Nice and easy. All right, doctora. So here in the center, I have my medullary pyramids. Medullary pyramids. They kind of look like testicles. If you remember the brainstem, right? That image from the brainstem.
Yeah.
Kind of look like a scrotum or something. So that's what I remember them by. They're the medullary pyramids. It looks like a scrotum up in the brainstem. This little triangle is my thalamus. Okay, that's my thalamus. You can choose whatever shape you like. I just did that to keep things simple. But that's our thalamus. Above the thalamus, I have my caudate nucleus. All right. The boomerang, this little boomerang right here, is the internal capsule. Internal capsule. And this little slice of pizza is the globus pallidus and putamen. The globus pallidus and the putamen. Okay? Medullary pyramids, thalamus, caudate nucleus, internal capsule, globus pallidus, putamen. Got it? All right, good. So now let's discuss what do I have here. So in blue, I have my corticospinal tract. I want you to know that the corticospinal tract begins at the frontal lobe. Begins at the frontal lobe, and he moves downward. That's what you need to remember. Okay, begins in the frontal lobe and moves downward, contralaterally, of course. So he's going to go through the internal capsule. This is very important that you remember that he goes through the internal capsule. What was the blood supply to the internal capsule, Doc?
The MCA.
To the internal capsule?
Mm.
The internal capsule, doctora, he is part of the basal ganglia. So what's the blood supply?
Okay, I missed.
Lenticulostriatal
Oh yeah,
artery.
the lenticular, yeah, with this guy.
Yeah, exactly. So again, if I were to have a lesion of some sort, some issue at the lenticulostriatal arteries, I can have damage to the internal capsule. And if I have damage to my internal capsule or just basal ganglia, there's a high probability, that corticospinal tract is going to be affected. You see? So
Okay.
that's why it's important to know that he goes through the internal capsule. From there, he will decussate. That's a fun word. Decussate. I don't even know how you spell it. Decussate, I believe. I may have spelled it wrong. I'm not too sure. But
And they
decussates.
cross.
They cross.
Yeah.
Basically, it just means cross. Like, why didn't you just say that? Huh? It crosses over at the medullary pyramids. It crosses over at the medullary pyramids. Meaning, if I were to have a lesion at the medulla, well, there's a high chance, probability that corticospinal tract could be potentially affected. Make sense?
Mm-hmm.
All right, good. And then he inserts contralaterally. That's corticospinal tract. Versus.
So he likes to zigzag.
Basically.
Yeah.
All right. Versus the dorsal column, now in yellow. Dorsal column. Now, dorsal column, he comes in, let's say at around, let's say he's, well, what he does, he just comes in and he moves up, crosses at the medullary pyramids, goes to the thalamus, and then inserts into the parietal lobe. Okay. Let's say this is gracilis. Let's say this is cuneatus. Okay. Cuneatus is a little bit higher, like around T5 level, more or less, right? But either way, the fibers, once they enter, they go up, they decussate, okay, at the medullary pyramids. As a matter of fact, they wave hello to the cortical spinal tract on his way down. He's like, how's it going? No, I'm going to work. And yourself, you know, we're coming back home from work. Go have fun. See? They're just passing by each other on the highway. And then it goes, like I said, to the thalamus and to the parietal lobe. So frontal lobe, I want you to remember movement. Movement. Parietal lobe, I want you to remember sensory. If a patient were to get punched in the parietal lobe, I know it's crazy, right? But if we were to have a lesion in the parietal lobe, guess what? They might have some sensory issues. Okay. I'm just trying to show you some concepts. Just so you understand the bigger picture. Okay, good. So that's basically how he works, right? Then I have spinal thalamic tract. Now, pay close attention to this guy. Spinal thalamic tract is a little bit, he's a little weirdo. Let's say, hypothetically speaking, we're at level T6. T6, spinal thalamic tract. So now I'll put in green. Spinal thalamic. There it is, right there, ST. So let's say we're at T6. What happens is that he comes in at T6, he goes up 2 vertebrae, and then he crosses in the spine, meaning he doesn't wait to go to the medullary pyramids. He crosses in the spine. Okay.
Okay.
It's wherever he comes in. It doesn't matter from wherever he's coming in, right? Because they're doing this, right? Just like the dorsal column, right? They're both going up. But wherever he comes in, T6 or donde sea or anywhere, he's going to move up 2 vertebrae and then he crosses over. Then he moves up. Here's what's important. Because he already crossed, right? Then he's not going to cross at the medullary pyramids. So he bypasses medullary pyramids, goes to the thalamus, and again, enters into the parietal lobe. You see that?
Mm-hmm.
All right. The reason why I'm drawing all of this is because, Doc, what if you had a patient, what if your patient had a lesion right here? As you can see, I left it in red, right here. What if he had a lesion right there? Well, let's just go one by one. Yeah, what track is right there? Just go one by one. Well, we have cortical spinal tract.
Yeah,
Right,
cortical
okay.
spinal and dorsal column.
Dorsal column and
the spinal thalamic.
And spinal thalamic. Okay, so here's my question, Doctora. Cortical spinal tract. The presentation, would it be ipsilateral or contralateral?
It's gonna be contralateral.
Contralateral, but the lesion's right here.
Oh, yeah. It didn't cross.
Exactly. Remember, cortical spinal tract is coming down.
Yeah.
So it'll be on the same side. You see that?
Mm-hmm.
Okay. What about dorsal column? What about dorsal column?
It's gonna be. You see. It's gonna be ipsi.
Also ipsilateral. Yeah, you got it exactly because it's on the same side. See that? Same side. What about spinal thalamic?
If it's no, he already crosses.
That's right. So
that's gonna be contralateral.
Hey, so that's what I'm talking about. Ipsy, contralateral. Ipsy, contra. When I see that combination, ipsy, contra. So ipsy movement, ipsy vibration, contra pain and temperature. This is known as, do you know? Brown sequard.
Oh, brown sequard.
Uh-huh. Call it the hemisection. Now it makes sense.
Yeah.
Guaranteed to come up on the exam. But I found that if you understand brown sequard, then that means if you're able to understand Pro C4, then that means you understand the tracks very well. Okay, because now I can say, let's say you got into a fight with some man who's trying, with some woman who was trying to get your man. Man, you don't play that. So you hit her on the side of the head. You hit her on the left side frontal lobe area. You popped her in the head. Boop. You hit her real hard. And now, because you hit her in the frontal lobe, what track could be affected?
In the frontal lobe.
Uh-huh. What track originates in the frontal lobe?
Yeah, the CST,
Excellent. Cortical spinal, muy bien.
cortical spine.
Okay. And you knock her really, really hard. You knock her out. You knock her out. You know, because you weren't feeling it, right? She said some things. So if you knock her out in the frontal lobe, what's going to happen is we might have a lesion of the cortical spinal tract. And if we do, is she going to present with ipsilateral or contralateral movement disorder?
At the frontal lobe.
Yeah.
Okay.
Would it be ipsilateral or contralateral movement disease?
Ipsilateral.
You hit on the left. Follow the tract. It's over here on the right. You hit her over here is what I'm saying.
Oh, okay. It's gonna be ipsilateral.
No, contralateral, doctora. You hit her here and she lost it here.
Okay.
You got it? Contralateral. But if you, I don't know, you stabbed her in her back, literally, then it would be ipsilateral. Do you understand?
Yeah. It's because I mix because sí, porque in the origin is go from the top to the bottom.
Exactly. So exactly. So it goes that way. So with that being said, you hit her in the top of her head and you caused a upper motor neuron lesion. You see, upper motor neuron lesions usually tend to be contralateral, whereas lower motor neuron usually tend to be ipsilateral. Now you can take this note and try to memorize it, or just look at the image and make sense of it. You say, well, of course it's going to be ipsilateral. Anatomically speaking, it has to be. You see? Yeah. So upper motor neuron lesion, everything is up. Okay. So hyperreflexia, hypertonicity. Okay. Versus lower motor neuron, everything is low. So hyporeflexia, hypotonicity, and fasciculations. Okay. Very good stuff. Very good stuff. All right. So yeah, that was that. I believe, yeah, that was that image. Let's see, what's next? The eyeballs. Yeah.
My favorite.
Oh yeah, everyone loves this. Okay, so first things first, Doc. Let's make this nice and easy here. We know that the tracks, they kind of do this. Let's say, so here I have the eyes, right? Here's the eyes. Here I have my nasal fibers. Look what I did with the temporal fibers. Now, you know that the temporal fibers, usually they do this. Oops. Like this. You know that they do this, right? Looks like a spider. Right. But if you really look at the fibers, what I've done is I close this like so. Give me 1 second. Okay, sorry about that. Okay, so as I was saying, the temporal fibers, basically it's just to say that it does this is literally saying that it does this. It's the same thing, right?
Okay.
Make sense? Yeah. Okay, good. So this is what we're gonna do. Let's follow the fibers. The temporal fibers over here are looking at the nasal side. They get vision from the nasal side. The nasal fibers, they get vision from the temporal side. Make sense?
Yeah.
All right. Good. So Doc, let's say Again, that girl, she came back for more. She just doesn't learn. Let's call her Karen. She just doesn't learn. Comes back for more. Boom, you punch her now in the eye. Uh-oh, right? Because you took boxing classes. Punch her in the eye and it causes a retinal detachment. Uh-oh. What would happen if you cause retinal detachment? Boom, this lesion 1. See that?
Mm-hmm.
What can happen? What would they complain about? Or what would they complain of? So here's her eyes. What would be her complaint?
She will lose sight from both, basically, both fibers, nasal and temporal. So,
Exactly, i.e., monocular blindness. Can't see anything. That's a good example. Okay, a good example. Retinal detachment. Okay, it could be other things as well, but I just wanted to give you that example. You see? Cool. All right, but what if they lesioned here at 2?
until
Mhm.
she's gonna lose sight from the nasal part of the eye, so it's gonna be monohemianopsia.
It is the loss is going to be from the nasal field or the temporal field?
Wait.
Huh.
It crosses. That's
Just follow. Look at 2. It goes up. That's it. What
yeah.
fiber is that? The nasal or the temporal fiber?
The nasal.
Nasal fiber. The nasal fiber looks at which field? Nasal or temporal field?
Nasal field.
No, the nasal fiber looks at the temporal field.
Oh yeah. It's go to the
Exactly.
other way.
Look
The
at the
nasal
colors.
goes
Just look at
to
look
the
at the colors.
temporal.
Uh-huh.
Mhm.
You see that? Red in nasal is red,
Red and
and that's
green,
why. Uh-huh. And
and
then
green and
temporal is
red.
green. Yeah. You see that? So there it is, red, and then this is over here, right there, the red. So that's what they'll lose. You see? Again. So over here, what would they have then? They will have
Um,
the famous, what is it called?
the
Boom,
the lat the lateral
bitemporal hemianopsia.
bitemporal meninopsia.
Bitemporal hemianopsia. Classic cause, maybe pituitary adenoma,
Yeah.
maybe craniopharyngioma also. Maybe craniopharyngioma. Okay, good.
Mhm.
All right. What about this one then? At lesion 3. Look at lesion 3. Follow the fibers. Here
Okay.
I lose this one. So in this eye, what part of which eye am I losing? Which field am I losing? Nasal or temporal?
The nasal.
The nasal field is gone. So I do this. Okay. Nasal field is gone. You got it. You got it. What about in the other eye?
At the same level, it's gonna be
Here, the lesion is here.
the nasal as well. No,
Nasal
the temporal.
temporal. Very good. Exactly. Temporal. Contralateral.
Mm-hmm.
Contralateral hemianopsia. Okay, that's fine. Okay, that's lesion 3. Now look at lesion 4 before we jump to 5 and 6. Look at lesion 4. Isn't lesion 4 the same thing as lesion 3?
Yeah,
Yeah, it is, right?
basically.
So
Mm-hmm.
it should basically present just like this, right?
Yes.
Yeah. The thing is, look, we're all the way in the back. This area in the back is called the callicrine fissure. You say, what
Mm,
does that mean? That just means that it's in the back of the head. So posterior, okay, occipital lobe, posterior cerebral artery. The reason why this is important is because the fact that it's so far back, our macula tends to get blood supply from the posterior cerebral artery, the posterior area of the head or the brain, rather. That being said, Lesion 4 presents exactly like lesion 3, but with macular sparing. See?
Oh,
Yeah.
yeah.
Same exact thing. Just with the macular sparing. It looks like, I don't know, I don't know if your kids are into Pokemon, but it looks like a Pokemon ball.
Yeah.
Yeah. That's what I think of it, at least. Now, 5 and 6, check that out. 5 and 6 is basically just half of 3 or 4, right?
Yes.
Yeah, it's just half. Okay, good. So then let's look at lesion 3, and then what will be half of lesion 3? It would be, well, a quarter, right? See that? That's half.
Mm-hmm.
All right, good. So that's called quadranopsia. Quadranopsia. Okay. I'm going to show you how to figure out where and whether it goes to the right or the left in the next image. But I just want you to understand that basically, if you see quadranopsia, it's kind of like saying lesion of 3, lesion of 4. It's very similar. It's the same fibers. Okay. Just continuation of the same fiber. Okay. All right. Good. Oh, and by the way, I am going to send these notes to you. So just be thinking. Okay, let's see what else. What else do I have here? Here it is. Okay, so here we go. We're gonna start. Oops. We're gonna start over here, Doc. Here's our eyeball. Here's our optic tract, and here's the lateral geniculate nucleus. Lateral geniculate nucleus. Okay. Lateral for look at the light. Lateral, look at the light. Okay. The reason why I say that is because we have the medial geniculate nucleus, and medial, M for music, so auditory. Okay, hearing. Medial geniculate nucleus. Lateral, look at light. All right.
Okay.
This is where my fibers meet. The fibers from the last image, right? That I said do this, cross, and then they do this right here. That whole thing, they all meet at the lateral geniculate nucleus. From there, I have my optic radiation moving upwards and my Myers loop moving downwards. All right, 5 and 6, 5 and 6. Optic radiation moving upwards, Myers loop moving downwards, 5 and 6. Myers loop moves up, he's superior. Myers loop, I'm sorry, optic radiation moves up, he's superior. Myers loop moves downward, he's inferior. The parietal lobe is superior, the temporal lobe is inferior. Make sense? All right.
Yes.
So, Doc, what I want you to know is, as we've seen already on multiple occasions, in neuro, if you are ever unsure, just say contralateral. All right. For the most part, if you're ever unsure. I showed you some very specific examples of when it will be ipsilateral. The reason why I showed you those is because all the other ones are, for the most part, going to be contralateral. Yeah. And what I'm going to show you right now is no different. Okay. So if they say up, you say down. They say left, you say right. Okay. They say in, you say out. So let's say you have a patient and he has a left parietal lobe lesion. Where is he going to have the quadranopsia? What part of the eye? On the right, on the left, on the top, on the bottom?
On the top.
The top. They said left parietal lobe. Parietal lobe is superior. Superior. If they say superior, you say
inferior.
Inferior. Good. So I know we're down here. They said left. Therefore, you say
right.
Right. So therefore, I know it's over here. Right quadranopsia. Got it? Yeah.
Yeah.
All right. Vice versa now. They say left temporal lobe lesion. Right? Like herpes. Oh, they like that one, right? Herpes, HSV, causing encephalitis, maybe seizures. Left temporal lobe lesion. You say, okay, well, they said left. So therefore you say
right.
right? And they say temporal, which is inferior. So you say
Parietal,
no, superior.
parietal,
Superior.
superior.
Yeah. So I'm sorry, right. So right, superior quadranopsia. You see that?
Yeah.
All
Mm-hmm.
right. Good. Now, because we're Latinos, parietal, P, piso, P. So if it's a parietal lobe lesion, al piso, it goes to the floor.
Oh,
See
that's
that?
why you put it there. Yeah.
Guess what? Because we're Latino, temporal for T, techo for T. So it's a temporal lobe lesion, it goes to the roof.
Yeah.
Okay. Really quick for my non-speakers, my non-Spanish speakers. Piso means floor. Techo means roof. Right. Okay. It's just
Yeah.
an easier way to remember this stuff. Okay. I saw an example of a patient who was in a car crash and they hit the side of their head with the window. I'm like, oh, okay. So it was a parietal lobe lesion. All right. So here we have our ventricles, Doctora. Here I have my lateral ventricle. I have my foramen of Marilyn Monroe. I know it's Monroe, but I say Marilyn Monroe. I'll show you why later in a second. Here I have my third ventricle, my aqueduct of Sylvius, my fourth ventricle, which has this triangular shape. And then we have my foramen of Luschka and Magendie. And what they're doing is, or what you need to remember, is that from the lateral ventricles inside of our choroid plexus, we create CSF.
Mm-hmm.
And this CSF begins to travel downward and then it empties into this area, which is called my subarachnoid space. It's all this area that goes around the ventricles is my subarachnoid space, all of this subarachnoid space. And from there goes up through the arachnoid, this is subarachnoid space, goes up through the arachnoid granulations and it empties into the venous system. Okay. Empties into the venous system through the arachnoid granulations. And this is the subarachnoid. Arachnoid is a meninge, right?
Mm-hmm.
Okay. Patients get meningitis, right?
Yeah.
Itis means inflammation. And with inflammation, especially if it's chronic, you get fibrosis, strictures, scarring. What do you think? What would happen? What do you think would happen if you scar? If you scar the granulations? Can you empty the
Well,
CSF into the venous system?
no.
Nope. So what happens? It backs up, it accumulates, it backs up, backs up, backs up, and now my ventricles are huge. This is called
Mm-hmm.
communicating hydrocephalus. Communicating. Why? Because every ventricle is communicating with each other. Why?
Yeah,
Because
there's
it all started up here. You see? But
mm-hmm.
this one's enlarged, this one's enlarged, this one's enlarged, and these are also enlarged. Communicating. Okay.
Yes.
But let's say a patient had, I don't know, let's say tuberculosis. Tuberculosis has a unique effect of causing stenosis of the aqueduct of Sylvius. Well, guess what? Now everything before the aqueduct will build up. Everything behind it will decrease. So this is called a non-communicating hydrocephalus.
Mm-hmm.
Mm-hmm. All right. So let's keep talking now. We have on the floor of the fourth ventricle, this area called area postrema. And within the area postrema, let's just say like right here, we have our chemotactic trigger zone. All right, chemotactic trigger zone. These areas both respond both of these areas are responsible for vomiting. Okay, they are both
Okay.
responsible for vomiting. How I have it understood, okay, the the chemotactic trigger zone, he responds to an increase in pressure, increase in intracranial pressure. The area postrema responds to noxious smells, noxious smells. So example, I don't know if you're a fan of football. I'm not a big fan of football, but there are sometimes some things that you see right on TV, maybe movies, and you tend to catch some football players right in a movie or something. So what am I saying? What I'm saying is you might get that football player who has the concussion, right? He bumped heads with another football player, maybe a bigger guy, and then you have your football player, he had a concussion. So he bumped his head, it caused trauma, it caused inflammation of the brain, and therefore increased intracranial pressure. The increase in pressure eventually causes stimulation of the chemotactic trigger zone, and that's why even though he's sitting down, recovering, he starts to vomit. You're like, why is he vomiting? Did he have some bad tacos or something? No, it's because of the increased intracranial pressure. You see that?
Mm-hmm.
All right,
And
good.
it's,
Huh? Go ahead. You
no,
want to say something?
I'm just making the connections with
Oh,
the,
perfect.
yeah.
Good. Okay. And then here's another one, something that maybe you're more accustomed to. You can relate to. You can relate with a little bit better. Noxious smells. So you have a baby, and your baby, he poops. And when he was maybe 1, 2 years old, it smelled cute. It smelled really nice. It was cute. But now that he's 3 or 4 or older, it smells nasty, like grown man. And sometimes when you're not expecting it, you get a whiff of that poop, and then what happens? You feel like you wanna vomit,
Mm-hmm.
right? Another example, you've seen people on roller coasters, right? One guy has an upset stomach and he vomits, and then because the guy next to him smells the vomit, now he vomits also, and then everybody starts vomiting in a line like dominoes. Okay? Yeah. Yeah. Now, really quick, how do I remember Lushka, Magendie, and Monroe and their order? So I remember Marilyn Monroe. Marilyn Monroe, I don't know if you remember who she was. I just know her from
Yeah.
pop culture, right? She was that woman who infamously wore the white dress. She was on top of the I don't want it's not the train track. What is the subway kind of thing? Whatever it is where the trains pass underneath and then all that wind blows up. I forget what those manhole covers, something like that. I
Yeah.
forget what they're called,
Mm-hmm.
something like that. But anyways, the point is she was on top of this and the wind was blowing up and what was she trying to do? She was trying to keep the dress down because she didn't want anybody to see her cookie, right?
Yeah.
But what if we had some perverts underneath that train or underneath that that rail, if you will, like the Lushka twins and Magendie? Maybe they knew that Marilyn Monroe was going to pose for pictures in that specific area, so maybe they went through the subway system and just waited, and they kept looking up to Monroe. You see that? So that's just kind of how
Mm-hmm.
I think of it. All right. If it helps, good. If it doesn't, I tried. All right.
Yeah.
Yeah. So very good. Those are the ventricles. That's what I wanted to say about that. Um, okay. Yeah, that was it. That was it. Perfect. Next one, ventricles, and okay, last one, Doc. We're going to talk about some diseases now, just a couple of buzzwords for dementias specifically. So before we even get to that, before we even get to dementia, let me discuss this really quick. Dementia, because they really like to ask this. Okay, dementia versus delirium. Do you know any differences between the two? When somebody's delirious versus somebody's demented.
Um, First of all, the progression could be, no?
Okay, I like that. I like that. How's the progression for dementia?
Slow.
Slow, prolonged, right?
Yeah.
Delirium is more acute. Very good, right? He's more acute. What's a cause of delirium or classic cause?
Um,
Be
um,
very
it,
generic.
Very generic.
Be very generic, yeah.
Let's say a change in the
Mhm.
in medication, also.
Okay, the change in medication may cause a change in electrolytes.
Yeah.
Yeah,
Oh, yeah, yeah, yeah.
see that? So yeah, electrolyte disturbances, maybe infection. You see,
Yes.
those are two classic causes. And now there's like, what infection? Well, it could be many infections, right? Which medication or which electrolyte disturbance? It can be many, 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 many. Okay. So it's usually acute. Their consciousness, that's what you have to remember. Well, wax and what is it? Wax and wane or wax and wan? I don't know. Comes and goes, right? Va bien.
Yeah.
Dementia is not like that. They don't lose consciousness. So the delirious patient, they'll say he's awake and active and argumentative and he's causing problems. And then he just fell asleep for 5 hours, 6 hours, maybe a whole day. He was just out. Then he's back up and he's aggressive. Very
Yeah.
strange. All right. Good. 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 Okay. So yeah, that's delirium. Now let's talk about the dementias. Okay. So we're going to start with Parkinson's, which is a type of dementia. We already spoke about him briefly earlier. Substantia nigra issues, the cogwheel rigidity, lack of dopamine, meaning the treatment will have to be give him dopamine, right? You have to remember that in Parkinson's, they have these unique Lewy bodies. Okay, Lewy bodies are seen, and these Lewy bodies are full of alpha synuclein. You say, what is that? Don't worry, it's just a protein. And it stains red, eosinophilic. So they'll talk about these little eosinophilic inclusions. And you'll say, what is that? Eosinophilic inclusion bodies. What? In Parkinson's, they're full of alpha synuclein. They're called Lewy bodies. Okay.
Okay.
So that's something I want you to see. Alzheimer's, everyone's favorite disease, right? That's when grandma and grandpa, they just forget things. Okay. So an issue with Alzheimer's, I want you to remember is that they lack acetylcholine. So therefore you might want to give them acetylcholine as treatment. Make sense?
Yes.
Like the Nepazil, right, which is a acetylcholinesterase inhibitor. Also, the issue is seen in the APP gene. This APP gene is called amyloid precursor protein, is a precursor for amyloid. And this APP gene is seen on chromosome 21.
Oh,
so the patient has, exactly, that's why.
Yeah,
so if you
Down
ever see a
syndrome.
patient, yep, you got it. Down syndrome, I love it. Muy bien. So anybody with Down syndrome, let's say you have a patient with Down syndrome, then you'll get at the age of 40. At the age of 40, they'll present with Alzheimer's. When you think of Alzheimer's, you should be thinking of like a 70, 80-year-old man or woman, not a 40-year-old. Okay. Once you see a 40-year-old with what looks like to be Alzheimer's, you're like, yeah, you probably had Down. Okay. All right. What else? What they'll also mention is on Congo red stain, you're going to see apple green birefringence. Apple green birefringence, which just means amyloid. Okay? Just means amyloid. Got it?
Yeah.
Get it. All right. Now, there's some other unique proteins that are seen. What other proteins are seen with Alzheimer's? Tau protein.
Oh, yeah, tau.
Yeah.
Tau.
And yeah, tau and the neurofibrillary tangles. I have it understood that these tau proteins, neurofibrillary tangles, it's due to oxidative damage. Ever read that before?
Yeah,
Oxidative damage. Go ahead.
Sí, daño por los radicales libres, the free radicals.
Exactly, free radical damage. You got it. Yep. So then that's why it's theorized. It is theorized that Vitamin E can help decrease the progression. It doesn't treat it, but it might help decrease the progression of the disease because vitamin E, as you know, is an antioxidant. You see? So vitamin E, being an antioxidant, is good for this to prevent any oxidative stress on these proteins. Don't forget also that vitamin E could potentially be given to prevent atheromatous plaques. Because again, that LDL, the LDL being oxidized with the macrophage causes giving you that foam cell and therefore the atheromatous plaque. Let's prevent that from happening and give them vitamin E. Okay. Now, Pick's disease, also known as frontal temporal dementia. Frontal temporal dementia. Because the frontal lobe is affected, yeah, you'll know that they will have movement disorders, but because it's also frontal lobe, I want you to remember personality disorders. Okay, so have dementia, personality changes, movement disorders. That's PICS. They don't really ask. I haven't seen them ask too much about PICS. I feel like it's too straightforward. So it's just not a hard enough question, I think. Know it, but I highly doubt you'll get it on the exam. All right. Lewy body, dementia. Well, guess what they have? They have Lewy bodies, kind of like in Parkinson's. So Lewy body dementia, I like to think of it as Parkinson's disease plus they hallucinate and then they have syncope. In Lewy body dementia, they have these alpha-synuclein eosinophilic inclusions called Lewy bodies. You see, it's the same thing, just like Parkinson's, cogwheel rigidity, movement disorders, etc., but they hallucinate. So one way I saw in the first aid, I don't know if they still have it, but it was they spelled hallucinations like this, hallucinations. Yeah. And I say, oh, that's really good. That's really clever. That's very clever. Hallucinations, perfect. And then they have syncope. Okay, hallucinations. I thought it was clever. So that's Lewy body dementia. Then you have multivascular or just vascular dementia. These guys, they get multiple clots and they get worse and worse and worse, days to weeks, for days and weeks on and on. They get worse and worse and worse. It's progressive and it's multiple clots. Just a lot of little infarcts all throughout the brain. Okay. So that's what I put down. They have what's called a stair-step decline, right? Empeoran. Every 2 weeks, for example, it doesn't have to be 2 weeks. I'll probably give you another interval, but I'm just letting you know, let's say every 2 weeks, it gets worse and worse and worse. Creutzfeldt's Jacob, in a way, also gets worse and worse and worse, but they tend to die within 1 year of presenting with the disease. They will die. Less than a year, they will die. In Creutzfeldt's Jacob, we have a prion disorder. They say, what the hell is a prion, right? A prion is basically just it's a type of protein, right? We have primary, secondary, tertiary, and quaternary proteins. I'm not going to get into that. It's just a subtype of a protein, and a prion is just that. It's a subtype of a protein. So we have alpha helical shaped proteins, and then we have beta pleated. Now, beta pleated looks like this. What I did was I put I made it look like a what's it called? A saw, a serruche, right? Is that what you say?
Own toothbrush also.
No, not a toothbrush, because I want you to think of something very, very sharp and dangerous.
Oh, okay.
Yeah. But okay, let's say, but this is basically right here, just that up and down, those little mountains, that's beta pleated. So the thing is, alpha helix goes to areas in the body that have a lot of twists and turns, like your hair, like blood vessels, right? Or your nerves, like the neurons in your brains, they're going all over the place, a lot of twisting and turning. Beta pleated, on the other hand, They have a lot of flat areas. You see flat, flat, flat. So they're going to go to flat areas, like maybe the flat bones of the face, or maybe the skin on your palm. That's flat. The dorsum of the hand, that's flat. You see that? Very different protein because it goes to a very different area in the body. Make sense?
Yes.
Okay, well then guess what happens with Creutzfeldt-Jakob? In Creutzfeldt-Jakob, you have a conversion of alpha helix to beta pleated. Uh-oh. So we're supposed to have a lot of alpha helix in the brain, twisting and turning, but then we get this sharp knife-like saw or serruche, and what it does is he goes in and out, in and out, in and out of the brain, making little holes in the brain. And now the brain looks like a sponge. They call it spongiform encephalopathy. Creutzfeldt-Jakob, spongiform encephalopathy, bovine encephalopathy, mad cow disease. Okay. It causes rapid death. They have a very unique presentation in that they have this thing called startomyoclonus. You ever heard of that before? Startomyoclonus. You scare them, they seize up, tense up, and they fall to the floor. You ever seen those? This was a couple of years back on when YouTube was like a new thing, but there was these videos that went viral of some sheep in Europe that when you scare them, they kind of freeze up, right, and then they fall on their backs. I don't know. People would scare them on purpose. It was a big thing. It was a fad. I don't know. But anyways, I think of those sheep whenever I think of Creutzfeldt-Jakob. You scare them, they freeze up like that sheep, fall on their backs, arms and legs up to the air. Startomyoclonus. And then here's a very, very, very unique and random detail, but it's pathognomonic for Creutzfeldt-Jakob. In the CSF of a patient with Creutzfeldt-Jakob, you're going to have this protein that's called 1433. Don't ask me what it means. I have no idea. It's just called 1433 protein. Okay. You see that in a patient who presents with, again, dementia that's rapidly progressive, and maybe they died at the end of it. Probably going to be CSF. You're going to be looking for 1433. Okay.
Okay.
All right. Good. 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 Good.